Welcome back on to our topic of treatments for mental health disorders. We are going to jump back in with our final type of psychotherapy, which is behavior therapy, sometimes called applied behavior analysis. This is using learning and conditioning principles to address mental disorders and developmental disabilities. This is a focused action therapy, some would say, because it's not worried about the deep rooted causes or insights into why you're like that and where did this disorder come from, but rather it takes the idea that if maladaptive symptoms, things like depression, phobias, anxieties, are learned, then why couldn't we also use learning principles to teach someone new constructive behaviors? So that's where a term called counter conditioning comes in. So the goal of behavior therapy is to counter condition, to condition someone to produce new and good responses, healthy responses to stimuli that trigger fear or bad behaviors or maladaptive behaviors. So instead of always looking to drink alcohol when you need to be in stressful situations or avoid airplanes because you have a fear of flying, what else could you do instead? One approach to counter conditioning is exposure therapy. The other is aversive therapy, and we're going to take a look at both. In exposure therapy, like it sounds, it exposes the patients to their fears repeatedly in order to lessen their anxiety. So, kind of forcing them to confront it. And there is a strategy called flooding where you force someone to confront it all at once. But more likely, someone is going to be coached through systematic desensitization. This is when a therapist would coach their patient to associate a relaxed state with increasing anxiety triggering stimuli. I know this is a mouthful. I'll break it down on the next slide. This strategy is commonly used to overcome phobias. So let's take a look at how it works. So, what you would do first is your therapist would ask you to rank these phobia stimuli, the parts of a phobia, into a fear hierarchy, which I described as ordering the parts of your phobia by intensity. So, if you look at this example on the side here, let's say your fear is public speaking, maybe that is the ultimate fear. Well, maybe by ranking it, we could start by saying, well, first we have to pick our topic. Then maybe we watch other people publicly speak. Maybe you practice your presentation alone, and so on and so on. And as you have to deal with each level of your phobia with the increasing anxiety based intensity, you are also taught to use relaxation techniques and given other mental stimuli to focus on to help you remain calm. So it doesn't flat out get rid of the fear or anxiety, but rather it helps you deal with it when you have to. It utilizes biofeedback. So this is when you are listening to your body and trying to regulate your sympathetic and parasympathetic nervous system to help your anxiety or depression. So perhaps like almost like in baby steps. So identifying your topic and saying to yourself, like, okay, I'm still calm, cool, under control. What are the feelings that I feel when I watch someone else do this? What does my body do when I'm presenting by myself in front of a mirror? And actually trying to acknowledge the maybe increased body temperature, the increased heart rate, the increased breathing, but then pausing or finding ways to make your body calm back down. This also supports the idea of habituation, which we learned in conjunction with sensory adaptation. We're kind of getting used to it. Or by doing it so much, you kind of get bored of the anxiety and you're like, you know what? It's not that bad. It's not that big of a deal. So by attacking this level by level and then training your body at each step to have a different response, different reaction, it should help diminish the impact of that phobia or the anxiety or the depression. Aversion therapy is the other type of counter conditioning where you associate an unpleasant state with an unwanted behavior. So, for example, you might pair a negative stimuli with smoking, nail biting, drinking, and so on. Let's say unconditioned stimuli is a drug that causes nausea. Okay, there is a drug out there that we know creates the unconditioned response of making you nauseous. Well, if you take something like alcohol, and let's say you're trying to get yourself to stop drinking alcohol, and then you take this drug that makes you feel nauseous every single time you take that drug, eventually you will learn to associate or pair alcohol with feeling gross and feeling nauseous. So that might help you avoid drinking again in the future. Another example might be relatable for some of you, which is perhaps you bit your nails when you were a little kid and your parents put very gross tasting fingernail polish on your fingers. The idea there is when you would put your fingers in your mouth to bite your nails, you'd be grossed out, spit them out. And so again, type of counter conditioning. You now associate biting your fingernails with this gross taste, and so you would stop doing that behavior. A final style of behavioral therapy is behavior modification. Again, sometimes called applied behavior analysis. But basically, this is when desired behavior is rewarded and reinforced, and undesired behaviors are not rewarded or are even punished. So, this behavior modification is based on operant conditioning. The most common example is a token economy. This is when you earn secondary reinforcements that can be exchanged for larger rewards. So, for example, you might earn literal tokens like poker chips, or maybe you earn stars, or maybe you earn points, and eventually they can be traded in for something. So secondary meaning learned. You have to learn what those tokens or stars or stickers or whatever mean. And so an example might be a patient who is maybe an inpatient at a mental hospital program earns tokens for desired behaviors, like the doctor wants them to get out of bed. So every time they get out of bed, they earn a token. And eventually they can use those tokens for privileges or treats that they want. So perhaps 2 tokens means extra TV time that night. So this kind of exchange goods and services reinforcements, probably a fixed ratio schedule of reinforcement system is going to make someone modify, change, improve their behaviors. Criticism on this process is that maybe it's too dependent on extrinsic rewards and you're not actually teaching someone why they should want to get out of bed on their own. It also maybe puts too much power on the therapist, and then what happens when they are not in that inpatient or the therapist relationship anymore? Will that behavior still be improved? To wrap up the talk therapy topic, let's talk about the difference between group therapy and family therapy. In group therapy, the advantage of getting together with other people needing therapy and the same issues or same topics is that the clients benefit from knowing that others have similar problems. They can get feedback on new ways of behaving, not just from the therapist, but from other people going through it. It can help more people in a larger amount of time, and it can cost a lot less than traditional one-on-one therapy. While this is considered a type of cognitive therapy, it is also considered an outgrowth or an offshoot of the humanistic approach because others in that group setting are likely to validate you, accept you, be empathetic towards you, things like that. Family therapy is not all that different, except the group is the family. And it treats the family as a functional system. It helps members identify their roles within the family. Are you the caretaker? Are you the one needing care? How do we respond to one another? And the goal is to help improve communication amongst the family and discover ways of preventing or resolving conflicts in the future. And it's fully acknowledging that in a family setting, your behaviors affect one another. So, how do we recognize that? And then, how do we improve it? Okay, big topic shift. Now we're going to talk about biomedical treatment of disorders. So, medications and medical procedures that someone might undergo. So, beyond talk therapy, what are some other things doctors might try? They might try psychotropic medications, very similar to psychoactive drugs that we talked about back in Unit 1. I'm going to go down to the second bullet point, and then I'll back up. These interact with specific neurotransmitters in the central nervous system and address the biochemical causes of mental disorders. So, if the reason or a contributing factor to the mental disorder is something like an imbalance or overactivity or underactivity of a neurotransmitter, these medications can help right that and help those neurons fire properly. The increased use and effectiveness of these medications has helped improve or lead to massive deinstitutionalization from hospitals and asylums in the late 20th century, meaning in the 1800s, early 1900s, so many people would still be committed to things like insane asylums because their families and communities didn't know how to help them. But especially in these really severe cases of things like schizophrenia. But as medication has improved, people have been able to manage symptoms, and then it also makes things like talk therapy more effective when the worst parts of their symptoms are under control. And so it's just helped improve mental health treatment overall. However, side effects are often the reason that people don't want to use these medications. I want to give you an example of one of them. One of them is tardive dyskinesia. This is a movement disorder related to the regulation of dopamine in the nervous system. So one drug for schizophrenia, a antipsychotic drug, helps block dopamine receptors because remember, one part of schizophrenia is overactive levels of dopamine. And so by blocking the receptors, it decreases that level. While that's great, dopamine is also involved with a person's body movements. So if that dopamine's not flowing like it should, it could have an adverse reaction and create these tics or weird or uncomfortable body feelings and reactions. And that's called tardive dyskinesia. It might be so severe that someone who experiences that doesn't want to take the medication, even if it helps them with their schizophrenia symptoms. So let's take a look at this chart. You do not need to memorize the whole thing, but this chart tracks the type of medication. Oh, and sorry, not psychoactive, psychotropic medication, and which disorder it matches up with, and a brief explanation of how it works. Then I give you some examples of terminology maybe you've heard of on TV or commercials, advertisements, whatever, but also the potential side effects and why someone might not take it. So antidepressants help with depression symptoms, anti-anxiety drugs help with anxiety symptoms, and so on. A couple things to note. Antidepressants inhibit the reuptake of serotonin and norepinephrine. So it's supposed to help improve mood, stabilize and improve moods, and help with lethargy and things like that. Anti-anxiety drugs are supposed to depress, slow down your central nervous system by elevating GABA, which is a inhibitory neurotransmitter. Lithium is very effective for bipolar disorder in how it reduces manic activity. However, at too high of levels, it can be toxic. So it needs to be highly regulated by between a doctor and a patient. And then antipsychotic drugs, as I was saying, block dopamine receptors. They are meant to help with experiences of psychosis found in schizophrenia and other disorders. But you can see this list of side effects. All of these could be reasons why someone doesn't want to take one of these drugs. It might be more common to you. You might have heard of examples of people not wanting to take their ADHD medication because they feel like it perhaps creates kind of that feeling of drowsiness or lethargy if they haven't found the right dose that works for them. Same idea. Someone might not like how one of these drugs feels. And so even though it might help with one set of symptoms, if it creates another, they might not be willing to take it. Okay, next we have 3 types of procedures that someone might undergo to support their mental health disorders. Well, not support, manage. The first one is electroconvulsive therapy, ECT, also known as shock therapy. This is only used in severe cases of depression, but it seems to work. And doctors and researchers think it seems to reset the hypothalamus, readjusting hormone levels by causing a seizure. Let me reassure you that in modern medicine, this is not necessarily a traumatic procedure. A patient is put under anesthesia. They are given muscle relaxants. It is very short, 30 to 60 seconds. It might be repeated over a couple times a week, but once it seems to work, my understanding is that it can help for up to 6 months or more at a time, and often can reset a person to the point where then they can further explore other medications or other types of talk therapy to help them. We also have Transcranial magnetic stimulation, TMS. This is when magnetic fields stimulate the nerves in the brain, therefore activating regions that have decreased activity during depression. So both of these are used in cases of extreme depression. This one, the person doesn't even need to go under anesthesia. I'm not sure what they actually feel, but they're just kind of put into an intense magnetic setting. And in both cases, it seems to help reset the brain or reorganize the brain. And that is further evidence and support that there is a biological component to major depressive disorder. And then finally, psychosurgery, sometimes known as lesioning the brain. This is the purposeful procedure to sever nerves or damage the brain on purpose between the frontal lobe and the limbic system. Apparently, this is the part. I'm going to actually read my notes on this one. This one's tricky for me. No other part of the brain has found to be sensitive to surgery in such a way as to produce an improvement in affective and anxiety disorders, except doing this. Sometimes it can also be used for phantom limb pain, but that's not really a mental disorder. This is often used for severe OCD. Yes, it's the same thing as a lobotomy, which means actually taking out part of the brain to cure a mental disorder. Um, very, very, very rare. Okay, I just want to touch on two alternative psychotherapies you maybe have heard of. One is hypnotherapy, also known as hypnosis. I will go through these kind of quick so this doesn't get too long. This is a heightened state of deep relaxation and focused concentration where you are so relaxed that you are more open to the gentle guidance from a therapist to modify or replace your unconscious thoughts. It is effective in treating pain and anxiety, sometimes phobias, and while there does seem to be some basis that hypnosis can be effective in this way, research does not support the use of hypnosis to retrieve accurate memories or regress in age. So that's a myth, that idea of pulling out those repressed memories or acting like a child. No, it's more it's almost like combining behavioral therapy or taking new suggestions of how to act going forward, not so much dealing with the subconscious inner conflicts. The final alternate therapy I want to tell you about, not necessarily the final one that exists, just the final one I'm going to teach you about, is eye movement desensitization and reprocessing, EMDR. This is when I'm not even going to try to recreate it because I feel like that would be disrespectful to the process. But apparently, a patient moves their eyes back and forth in a specific way while remembering traumatic experiences. This is said to reduce the vividness and emotion connected to memories and helps the healing of the mind. I'm a little unsure about how it works, but there's a lot of research that explains that justifies that it does indeed work, especially for those with PTSD. Sometimes there's even hand motions involved, and it's something about being able to bring a traumatic memory to the surface, reprocess it instead of reliving it. And then it helps the brain kind of heal going forward and makes the person, as they revisit that memory, feel like they are just processing it as a memory instead of being brought back into that intense moment like you're being forced to relive it over and over again. Okay, no notes here. I just want you to see within psychotherapies, cognitive therapies are most widely used, followed by psychoanalytic and family and group therapy. So cognitive and cognitive behavioral make up about 50% of the therapy that are utilized. All of these are offered. Of course, it's up to the patient to find what works best for them, which leads me to which one does work the best? Well, it's not really about the one being the best. The types of therapy aim to tailor specific treatments to the specific problems. And we have this category of empirically supported therapies, or this label of empirically supported therapies, which means it's based on research as to which type of therapy is most effective for which type of disorder. So we know for depression, behavior and cognitive therapy is effective. For anxiety, exposure therapy and cognitive behavioral CBT is effective. For something like bulimia, cognitive behavioral therapy. For phobias, behavior and exposure therapy. And overall, regardless of the type of therapy, after a meta-analysis of over 475 studies, what was found of all types of people who underwent psychotherapy, that people who received treatment were better than 80% of untreated individuals. So you can kind of interpret that to say no matter what type of therapy you attempt, you are probably going to be, if you are struggling with mental disorders, you are going to be better off than someone who does nothing at all. Um, in other words, psychotherapy is generally considered effective. Final slide is the client-therapist relationship. This is the cornerstone. This is the most consistent role in the success of all forms of treatment. The therapist has a responsibility to demonstrate cultural humility and respect who someone is, their values, and where they come from, because if things like religious differences and cultural values are not respected, it can create miscommunication and mistrust. And if you don't trust your therapist, it's not going to be effective. Therapists also need to uphold ethical standards to ensure no harm. They need to practice non-malfeasance, which means your goal is to not cause maladaptive or other bad behaviors, that you're only helping to improve someone, that the treatments are carried out with fidelity, with loyalty, faithfulness, honoring commitments, honoring confidentiality. Actually say that instead of honoring commitment, say honoring confidentiality, that they are that they are treated, that patients are treated with integrity, and that therapists are always trying to do the best job that they can do and be up on best practices, and that they maintain respect for people's rights and dignity. Well, I went over my 20-minute mark. Here's one final screen for you. Nothing to take notes on, but to remember, both with disorders and treatments, and really most things in psychology, these treatments are biopsychosocial. There's a biological component, a psychological component, and an environmental component that you can read all those to yourself that will contribute to the success of the treatments, the success of the therapy, and the improvement of mental health disorders. All right, you have made it through this part of the lecture. I'm sure there's other things I will teach you here and there, but otherwise, you maybe possibly finished your last video lecture in this class. Congratulations.